All right. Yeah, then you guys ready to get started? You have anything to go need a potty? I see some patients I don't recognize. There's Sasuke against you. Yeah, I'm a medical student. I'm looking professor. I'm a pharmacy student. Press up, Nick. What do you guys want to be when you grow up? I am. Nephrologist. Well, yeah. Yeah. Hey. Hey, Adrian. All right. So, I need those. Oops, we're not the right. Director, I don't think I've given those to any of you guys because I think it's been 2 years since I've given it. I made an email this talk to some of you. I know that probably years ago when Manny was still a resident, I sent him Coral and Astral Trials. You did. And I never forgot it. You were so excited.
We talked about Poro over beers. That was our best journal, Chloe.
Yeah, that was a really fun one. Yeah, again. So we're going to start out with 2 cases, and each case has a question. So what I want you guys to do is don't shout out your answer. I want you to write down your answer or keep it in your head, and then we'll revisit it at the end, and we'll see how you fared. You don't have to reveal what your answers are and if you got it wrong or right, unless you want to brag. But I think it's always nice to feel like not get yourself low, but probably some of this stuff when I was a first year fellow, I wouldn't have known. Although I guess I supposed to be second years, I think the third year.
Third year.
We'll know this, but anyhow, maybe you won't know all of it. Okay. So I'll read the 59-year-old man with coronary artery disease and carotid stenosis, adipose CEA, referred for difficult control hypertension. He's had hypertension for over 25 years. Blood pressure has been chronically suboptimal, but it has recently worsened. The blood pressure is now 160s over 90s, and similar values were obtained at home. He denied use of NSAIDs and had been adherent with a sodium-restricted diet. He had a history of OSA treated with CPAP. He has no history of headache, palpitations, sweating, or family history of hypertension. He has a 40-pack year smoking history, but quit 5 years ago, and he denies alcohol use. He had been adherent with his medication that includes carvedilol, chlorthalidone 50, and hydralazine under POTID. He is also on atorvastatin and aspirin. So whenever you get this first consultation, what are things that you guys are thinking about? Like, so is this resistant hypertension?
I think about, why is he on a ACE or an ARB with this coronary artery?
Yeah, absolutely. But so now, is this resistant hypertension? Because we're going to get these consultations all the time. What's the definition of resistant hypertension?
3 meds, 1 diuretic, maximum doses, still hypertensive. And now it's all resistant hypertension.
Right. Well, so 3 meds, 1's a diuretic, or 4 meds, max out. So that's essentially resistant hypertension. And then, of course, you're ruling out all these other things. So you want to make sure it's not pseudo hypertension, right? So you're confirming that their home blood pressures are actually elevated and that their in-office blood pressures are actually elevated. And then you're ruling out non-adherence, right? That's the most common cause of quote-unquote resistant hypertension. And then the next one is inadequately treated with a diuretic or a really high salt diet. So for him, I mean, it actually seems like somebody's been doing their best they could with this gentleman, except that maybe he's not on a RAS inhibitor, which doesn't make sense. But maybe there's a reason for that because this is a case that we're doing. All right. So this is my prompt to go through the whole process. So we talked about what the definition of resistant hypertension is. So our BMI is 38 kilos per meter squared. Our blood pressure is 165 over 94. Our fundusstopic exam with grade 2 hypertensive retinopathy, and he's got no lower extremity edema. So this to me is telling me that he's had long-standing uncontrolled hypertension. He doesn't have edema. He's very much overweight. All right. So let's talk about our labs. What do you guys see here? Or just
The renal panel. Like heart renal high. K might be slightly low sometimes.
A little bit of CKD.
Okay. So it seems like they might have some chronic CKD stage 3AB, depending on how big they are. They're borderline hypokalemic and metabolic alkalosis. This kind of stinks of something, right? Something that we're always thinking about. And you usually think you look at this pattern and what is the first thing that pops into your mind?
Hyperaldo.
Right. But we know this has been a hyperaldo talk today. Well, it's not a primary hyperaldo talk today. But there are other things that can cause this pattern. That's just the one that we know well, right? I'm already out of order.
Put an arm on it. See what happens.
All right. So what do you guys want to know now?
Guess you should check out reading in that all day.
Check the whole beat compile.
If you don't believe them, what do you think? Collection, yeah.
Believe I'm getting real like, are you really though? And then like, well, I didn't really like my mask, so I work 1 hour at night. And then I wake up in the morning and it's all over the place. It's kind of like me with headgear when I was a kid. But me put it in the morning, my headgear, I'm laying on it.
For your teeth?
Yeah.
I don't know the US that that's the cells that. Huh? Okay, so thank you for screening for everything else. He said he's not at his, he said he's taking his meds. We confirmed his home blood pressures are also high. His home blood pressures are still elevated. He's taking his meds and he's adherent to them. We're just gonna believe him, right? We try to believe him. Okay, so you want Arena and Aldo. That makes sense. Med students, do you know why he wants Arena and Aldo and MCC?
They know I'm a genius. That's all they write.
We're worried about like if we're alcohol and figured out if it's primary or secondary, they're both elevated versus if we're not going to get elevated at the opposite. But
now, secondary hyperaldos, if somebody's like hypotensive, typically they're volume down, right? And so they're responding appropriately. So primary hyperaldo, if there's some other cause of having an elevated aldo. So I think I went through this very quickly. Casey. All right. Let's go this is just for fun. Because I think we have time for it. What goes under the increased renin and increased aldo?
All right, first years go first.
You can always phone a friend. And if you guys want to shine, you can shine. So what's a low-hanging fruit? Like, what can cause an elevated renin?
Like, go through this thing.
no, I asked you to look.
You'll learn it, you'll forget it, and you'll learn it, you'll forget it. And when you know more, yeah, just say you know what? Obviously. Oh, but that's still hanging, right? So if you make it too much reading for some inappropriate reason, you're gonna have elevated aldo. Okay, what else? So that's secondary. So right now, this is, and actually you can't see the top. Hypertension,
Slow your mouse over.
hypokalemia.
Over like a bar, just like real nice over there, and then there you go away.
Yeah.
Move your mouse again.
No, you just move it off.
Oh no, answers.
It's the nose.
Right. What happens with renal stenosis? You decrease blood flow into the kidney. Like,
Do some aggressive wiggling. There you go. Wiggle that.
okay, I see. Thank you. Thank you. Okay, and then what's the last one? This is one that people remember.
Malignant.
Malignant hypertension. What's happening there? Yeah, right? But
I need skinny.
oh, so that's why do you have a patient who comes in with severe hypertension patient? Maybe they have an AKI, you get a renin and aldo, it may not be that helpful for you because you might get a high renin and not high aldo. And you're like, oh, maybe they have renal artery stenosis, or maybe they just have malignant hypertension. Maybe they have something else, but just so you know, it's a little bit less reliable. Okay, so those are the okay. Now you know all of them. Okay. Decreased renin, increased aldosterone. So this is the one that we always think about, primary hyperaldosteronism. What's the other one? GRA. which stands for glucocorticoid remediable aldosteronism. So basically there's a mutation that's really rare. And when you are, so aldosterone isn't supposed to be released in response to ACTH. But in this population, it is in response to ACTH. So if you give someone prednisone, you'll suppress it and you'll fix their problem. That one's cool.
In real, I like struggle in real life to see how you ever get there. Because like you'd have to just be like, I'm gonna try some steroids. Is that how it works? And then it gets better, and then you're like, I guess.
Yeah, I've actually never
Okay.
had
It's like a
steroids.
test thing.
I would probably send a genetic test
Yeah.
and then try and do that. And I haven't found it yet. I'd be like, I think this is it. I think this is the one. So I've never tried it. How much sherry should
The yellow Remus.
I don't know actually, because I haven't done it. I'm guessing it's not that much. It's probably just enough to suppress the axis. Okay, so then decreased or normal renin to decreased aldosterone. This is like the make little acid, right? So littles, that's when our ENaC channel is lost. So right, you put their sodium.
I think you're right.
And then we've got other things that are behaving like a mineralocorticoid. So too much cortisol. If you've got an ACT producing tumor, so that's Cushing's. If you've got other like congenital adrenal hyperplasia, wouldn't be in this guy. If you have somebody's on abiraterone, that's the one that I did with no one here.
Oh yeah, that's right. Yeah.
Let's see. Itraconazole and ketoconazole can do that. So that's going to block the conversion of cortisol to cortisone, which is inactive. So if you have too much of that, that's a mineralocorticoid. So a bunch of unusual things that can cause it, but that's kind of a fun one. Anyhow, all right. We're not going to go, that's just mechanism and shit, but we're not going to do that. So additional labs, aldosterone is 9, renin is 3.2. What does that mean to you?
Not well.
It's not Heinrich hyperaldo. So the UA has trace protein and blanded stick, but we do have 500 milligrams per gram on that spot. High urine sodium, high urine K, and urine creatinine. If you want to do a calculation, like too. So renal ultrasound, no hydronephrosis or mass, increased echogenicity. Right kidney is 9.5 centimeters, left kidney is 11 centimeters. So this is your question. Write down your answer and remember it in your head. Which of the following is the most appropriate management? Measure urine aldo excretion after sodium loading. What's that diagnose? Or confirm. Add losartan, add hydrolysis, or on hydrolysis. Measure plasma pre-metanephrines or perform SBP angio. Everybody have something in mind what they would do? Okay. Let's do case 2. 65-year-old patient with I won't go through as much with this one. With past medical history of CAD, OSA, hyperlipidemia, CKD, and poorly controlled hypertension. Seen in clinic for a rapid rise in serum creatinine from 1.9 to 4 over the course of a year, with the most rapid rise over the last month. 2017 workup revealed renin of 0.6 and aldosterone of 6.5. He reports home blood pressures are regularly 150 to 160. And now he's got new onset 2+ or edema. His blood pressure meds include hydrochlorothiazide 25 PIT, labetalol 400 PID, valsartan 160 BID, and hydralazine 100 PID. Blood pressures are still up. Heart rate's okay. He doesn't have crockles or wheezes, no JBD. He's got tons of edema up to his knees. Okay, labs are, renin is pretty high. All those 9.9. That's concerning, isn't it? Okay, still a little low, bicarbs a little high. Creatinine up. No hydronephrosis or mass. Increased renal glycogenicity. Kidney size, right kidney's 12.5 and the left kidney 7.3 centimeters. So what is the next course in management? Up titrate the patient's labetalol to 600 milligrams POTID to keep that blood pressure controlled. Order a captopril-renogram. Order an MRA abdomen and pelvis, or consult surgery for a nephrectomy. Okay, you guys just move it up. Everybody have it? What they would want to do? Okay, so let's talk about renal artery stenosis finally. So basically the way we think about this is it's either bilateral stenosis or you have a unilateral with single kidney, right? And so basically, why is it the only time that we're really going to see a presentation of renal artery stenosis? So let's say we've got bilateral on one side, you've got renal artery stenosis. What happens with the other side? Right. And essentially you get this natriuresis. And so it's going to compensate. So oftentimes you don't even realize it. So it will manifest as CKD resulting from atherosclerotic renal artery stenosis, or you can have renovascular hypertension. But an actual ischemic nephropathy is occurs up, and this is not renal artery stenosis itself, but it's the ischemic manifestation of it is a diagnosis of ischemic nephropathy with evidence of significant stenosis over 70% or greater than 60% with that's hemodynamically significant. And how can you tell something's 60% and hemodynamically significant? Usually, how do we tell that?
Measuring the velocity or like the diameter pre and post an artery, but that's usually like with invasive studies. I'm sure there's another way, and that's why you're.
Yeah, I mean, sometimes you'll see it if you put somebody on an ACE or an ARB. So you give them some RAS inhibition. That's what we do with our capital renogram.
If you have so if you have unilateral disease that you can identify, but their GFR is dropping pretty quickly, and you don't have kind of an alternate reason, would that not meet criteria for ischemic nephropathy? It'd have to be both.
Yeah, I mean, I think that you can always consider like, okay, well, I don't know what else is causing this. I'm going to probably treat this.
Got it.
Yeah. But I think that you need to have a high index of suspicion that you may not get what you want.
Yeah.
You may not identify the actual problem. Okay, so 70-80% narrowing leads to demonstrable core hypoxia, and then there's a lot of inflammatory and oxidative changes. Angiotensin comes into play, and angiotensin wreak havoc. Then you get this long-standing bronchial injury, and that's when it becomes irreversible. But it does account for less than 1% of cases of mild to moderate blood pressure elevation, so you do still need to think of it if you're having a hard time controlling it. But it's much higher in acute, severe, or refractory hypertension. So what are clinical manifestations suggestive of significant renal artery stenosis?
First, ACEs and ARDS. Okay.
And so what gets worse? The hypertension. Not necessarily the hypertension, but the kidney function. Yes, the kidney function. And what's worse? What percent? There's typically a number that we use. Over 30. Yeah. Greater than 30% and sustained. Okay. What else? Like flash. Right. So somebody that has flash pulmonary edema or refractory heart failure or edema. Doesn't always have to be pulmonary or flash pulmonary edema. What else? Doesn't have to be flash. Is it flash peripheral? Just peripheral. More just with that three. So acute severe hypertension, that's new onset. Difficult to control hypertension. Worsening chronic kidney disease. Variability of serum creatinine. These patients are oftentimes are hemodynamic. Diffuse atherosclerosis. So Ryan Flood likes to plot everybody's images and show their diffuse atherosclerosis. Sometimes I think he overlooks story, but I think it's a good habit to get into. Renal asymmetry. Both these patients have renal asymmetry, right? They're old. They all probably have coronary artery disease and peripheral vascular disease. Those are the main things. They have plus or minus abdominal bruit. When was the last time you guys listened to somebody's belly?
That's question.
I think plus minus abdominal bruit because I don't think it's a very reliable parameter. You're not going to be like, oh, no abdominal bruit. You're good. Yeah. Okay.
What about the retinal findings that you mentioned in the other patients? So like
Or just a sign it's chronic.
hypertension, basically.
Yeah, and I mean, just remember when you've got somebody who's got long-standing hypertension, a lot of the more acute interventions are not going to change what has right. All the remodeling has occurred, so that's just something to keep in mind.
So, in terms of like determining Like if someone has like retinal hypertensive changes, how do you necessarily determine if that's like malignant hypertension versus just chronic?
I mean, malignant hypertension is going to be like wool spots and like hemorrhages. And so somebody who's coming in with, systolics of the 160s, you're not going to see that. You're going to get, I don't even remember, up like the silver appearance, but it's going to more look like chronic retinal hypertensive changes and not some of the more acute malignant hypertension.
And since we don't do those eye exams and that's up though,
Oh, you don't do.
Yeah. Giving for sedation, you don't need to look in the back of somebody's eye to know that they've got chronic hypertension.
but I guess like just ophtho, do they specify the differences between, or is everything just hypertensive retinopathy to them?
I think no. There's hypertensive retinopathy, which is somebody who's got chronic hypertension, and then there's malignant retinopathy that's very specific to the convolutional spots and the plain hemorrhages, and it's definitely like an acute process that happen.
Okay.
All right. Well, who do we decide to investigate further then?
These people with resistant hypertension that are on 3 meds and are already.
Right. Do we need to be getting imaging for all of them? You can't control it with all of those.
Young.
You're like keeping embedded with like hypertensive emergency.
Okay, so you're saying that there is a specific population that maybe we should be investigating, but not everybody should be investigated.
Okay, better said than so.
I don't always speak eloquently, but I'll take that one. Okay, so only those who are thought to have a high likelihood of benefiting from a procedure. So you have to take into account who the patient is that you're presenting with and who's really going to respond. And those have a moderate or low likelihood of having clinically significant renovascular disease, and those who are responding well to medical therapy. And we'll go over the data in just a second and why that's a recommendation. We're also going to just talk a little bit about some of the flaws of the data, and we don't want to overinterpret the data. So the populations they have a short duration of blood pressure elevation prior to diagnosis of the disease of renovascular hypertension. There's a failure and tolerance of optimal medical therapy to control the blood pressure. Like, for example, our Hearst patients. Did we have him on optimal therapy? Probably not. Subrecurrent plaque pulmonary edema or refractory heart failure. Otherwise, that explains progressive renal insufficiency, particularly if proteinuria is absent. So it's the chronic kidney disease patients, proteinuria patients, that maybe are less likely to benefit. And then if you've got suspected, fibromuscular dysplasia in a young person, and they can be a little bit more challenging sometimes to diagnose. So our options, gold standard is an angiogram, but that's not typically practical and not easy to do. So our non-invasive choices are our duplex, our CTA, our MRA, and then we've got our capillary, our renal vein renin measurements, and our plasma activity. All right, so duplex is time consuming. It can be difficult. It's very center specific, so it's not always reliable. And, for a while, the VA used that film that was really good. I don't know anymore if they're good. And I think that's the big problem with that. Peak systolic velocities need to be greater than 180 to 200 centimeters per second to identify greater than 60% occlusion. And then that one does provide resistive indices. Why do I care about, or why does anybody care about resistive indices? What does that mean to you? So resistive indices are a reflection of what our intrarenal vasculature is. So we'll get to that. But I have okay. And but basically it's like a surrogate for CPD. And so sometimes if you've got resisted indices that are higher, it's a greater likelihood at CKD and they're not going to respond well. I don't have the data on here that looks at that because it hasn't been reproducible, but they think it's probably just a good surrogate for CKD. So CT angio, that little guy. Oh. And this is actually probably moderate. And then there's a collateral artery.
Wow. Man, what an ugly kidney fellow. Yeah.
Well, next, the other thing that's important to point out is you can see that actually this is and Nice
Beautiful.
speaker. This one's got them.
Kidneys not recovery. We're not sad like
Yeah, MRA. I think CTA is typically what people will go for first. It depends on the degree of kidney disease or progressive kidney disease. So for just very quickly on fibromuscular dysplasia, CTA is preferred. MRA is contraindicated, but it's not as useful. The problem is that oftentimes it's just the more moderate cases have a lot of intrarenal segments, which are not well captured with CTA. And so you need to use angio for that. But that will increase your risk of false negatives. So if you have a high index of suspicion, you should be looking to the looking for an angiogram. It's funny because Charles just was in my office, I think. Yeah, like literally in my office for like 2 hours going on and on about a patient, whether or not he was going to do the angio or not.
Oh, Charles knows about that.
He did. Oh, thanks. So appropriate.
Wow. Is it common to develop evidence of FMD like later on in life, or if you have it?
No, it's usually. I mean, I actually haven't. I work at the VA. I'm surprised they hit Charles at the VA out in the patient. It's pretty there, FMD. So to be honest, I don't know enough about it to tell you really well, but I think most people are presenting at a younger age.
Like, so my grandma got a CAT scan. It calls FMD. I'm like, she looked 93, but he has like flash, like hypertensive emergencies, which I'm like, obviously they're not going to do anything about it now. But like, has this been going on for a long time, or did it just like appear off?
Radiologist saying.
They're like, young girl.
I mean, how long has you been having the flat pulmonary edema? I mean, I suppose they're different. It manifests differently in different genotypes, and perhaps it can be slow progression. I don't know. I'm not going to be able to tell you too much smart. I haven't seen it. I deal with mostly men, middle-aged and older men.
Great population.
I haven't had a reason to look into that much more, but at least this is. You should be paying attention to that. If you really have a high index of suspicion, you should be doing an angio. So other non-invasive tests, you got a renin measurement, capnopril-renogram, peripheral plasma renin activity, but they all have a fairly poor sensitivity and specificity. Plasma renin, it's elevated in only 58% of patients with renal vascular hypertension. The first patients was like just 3. I mean, it wasn't low per se, but it was slightly elevated, but I wouldn't be like, ding, 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 this patient's, got a problem with renal artery stenosis. Renin may be suppressed by a high salt diet or volume expansion related to intrinsic kidney disease. Enhancement with captopril can be considered. It can be helpful in identifying pressure kidneys and having potential need for nephrectomy. Both the pressure kidney.
It drives your blood pressure if it's so stenotic that it's just like secreting more and more renal.
Exactly.
Yeah.
All right. I don't know why I don't have. I missed something there. Anyways, this is our capital renogram. And this can be helpful, right? Because it helps us identify maybe hemodynamic stenosis. So you've got a greater than 60% on the Doppler ultrasound, and you're trying to figure out if you want to do something about it. It's truly causing ischemia. So then you do, what you do is you do the infusion, and then you want to measure this. So this is, of course, normal. This is grade 1. And so if you're going to be,
You have to point there.
Huh?
You have to go back and show your screen.
okay. So, I mean, basically you're going to see what's impacted here is this is uptake. So this line here is uptake and this is excretion, right? And so impact or uptake will be impacted as will be the excretion. And then this is just a greater, I think basically the kidney function is done skews here. So it's a reflection of not good kidney function and also has to do with having some renal artery stenosis. So just understanding what it looks like, it actually looks somewhat similar to patients who are obstructed, except this is captopril, not Lasix.
And this is Charles' favorite test for anyone.
Yeah, no, and so if it is negative, the thing is that if it's negative, that can be helpful. it does have a lot of false positives. It can be also helpful to determine if you just need to nephrectomize the kidney.
I like Stu's plan where he just says, give an arm and recheck your labs and see what happens. So I was like, yeah.
Yeah. Oh,
That seems
like that for like our PowerPoint with your mouse. With your mouse. Just click edit.
Did.
Click more. You broke it.
I don't know.
You did the Capta Pro Lever grip slot.
Huh?
You had hidden the slot where you described the Capta Pro.
Why did they do that? It was accidental. Okay, well, I told you the important stuff. Okay, so who received their renovascular intervention?
Young people.
Is it an occlusive disease posing critical hemodynamic limitation of the kidney function? And is a condition of the kidney such that restoring the blood flow is likely to benefit it? So, opposing critical hemodynamic limitation, occlusion should be at least 60 to 75%. 60 is probably on the lowest. Remember what I said earlier, actual ischemia is thought to be greater than 70 to 75%. And that's presumptive. This is just sort of the Doppler ultrasound requirements and the pressure gradient. That's what you had mentioned, Marta. Okay, and so is the condition of the kidney such that restoring renal blood flow is likely to benefit? So if our renal resistive indices is greater than 0.8, you have to know what the trajectory of the kidney function is. What is the kidney size? Sometimes people will do a kidney biopsy, but that's rare. And the reason why they might do that is if you have like a hibernating kidney. But you're trying to figure out if that's a healthy kidney. So resistive indices, that's maybe a reflection of chronic kidney disease. Another thing is like, do they have albuminuria? Do they have CKD already? Are they getting better? Are they worse? Are they stable?
Is there like a ratio of kidney size? Because the first two patients that you showed have like big discrepancy. So
The first one have like a 1.5 centimeter discrepancy. The second one though had a big one, right?
So is there like a ratio that you're like, oh, this is probably too chronic and we're not going to restore anything here? Or
Well, so I would say the first one, this guy's had long-standing, well, we can talk about it. He's had long-standing high blood pressure, right? He has chronic kidney disease. He has proteinuria. So probably for him, we're thinking he's maybe not optimally controlled. It's not like his creatinine's been getting worse. Maybe we ought to just try and manage his blood pressures. So I wouldn't even image him. So, and I'll show you the data in just a second that supports that. The other guy, he's got a new finding of one kidney that's pretty much been taken out in 7 centimeters. The other one looks like it's a reasonable size, right? That's a much larger discrepancy. You feel like one kidney's probably completely atrophic now. So now you're worried that you have entered into the unilateral kidney phase. What's happening with that other kidney? Does that other kidney have renal artery stenosis? So that's what's going on in my neck with that one. Okay. So again, these are the patients that are likely to benefit from intervention. We already talked about that. So the Astral trial, this was a randomized controlled trial. It was unlighted. The inclusion criteria was a little nebulous when trying to go through it. But it says substantial anatomic atherosclerotic stenosis in at least one renal artery that was considered suitable for vascularization. Maybe is greater than 60% stenosis, but I think I had to do a lot of digging to find that. And then if the doctor was uncertain that the patient would definitely have worthwhile clinical benefit, that's when they were randomized to this trial. So a lot of these patients, if the doctor thought that they were going to benefit from it, they were immediately sent for an intervention. And then the rest of them were put into this. So the thing that's important with this is people are like, well, we know based on the Astral Coral trials, they'll just say blank statements. We know that people don't benefit from interventions. And that's not true. It's that there's a very large, it's basically the people on the fringes or the extremes that probably benefit, and the rest of them just need blood pressure better managed. So the intervention was endovascular revascularization plus medical therapy versus medical therapy alone. Follow-up was 34 months. There was 806 in the trial, 280 were revascularized. I would say most lesions were greater than 70%. That's actually probably closer to like 60, around 60%. And then there's like a 50 to 70% group that was close to like 25, 30%. So there's a lot of people included that aren't on the extremes here. And then the mean systolic blood pressure is 150. So that's not incredibly high either. So, the people that they ended up looking at here may not be the population that would benefit most. So this is diastolic and systolic and diastolic blood pressures compared to the revascularized and medical therapy group, and there's really no statistically significant difference. And then the primary outcome was first renal event, and there's no difference there. And then first cardiovascular event, no statistically significant difference there either. And then overall survival, no difference that way either. So the limitations is that the mean systolic blood pressure was 150 millimeters of mercury. Anyhow, so are we, revascularizing people that it really matters to revascularize? So I think that that's why this was in part a bit of a negative trial. A lot of the patients with flash pulmonary edema, a lot of the patients who have worsening chronic kidney disease, who have uncontrolled or refractory hypertension have already been sent to be revascularized. So this is sort of the patients that now we know probably don't benefit. So the CORAL trial, this was 2014. The physician was physician preference and pre-screening. They initially had an inclusion criteria of a systolic blood pressure over 155 while on 2 or more blood pressure medicines. And they had to have severe renal artery stenosis greater than 80%, but less than 100%. Or stenosis at at least 50%, but less than 80 with systolic blood pressure gradient at least 20 millimeters of mercury. But mid-study, so they could get more people into it, they decreased the requirement of a systolic blood pressure greater than 155. And then they added renal artery stenosis plus a GFR less than 60. So again, they sort of tweaked things mid-study, which is kind of a no-no, but they can improve the recruitments. So as endovascular revascularization plus medical therapy, over 60% were treated. And then medical therapy follow-up was 43 months. And then the mean systolic blood pressure for both groups was 150 millimeters of mercury, and the mean stenosis was 67%. So same thing, event-free survival, no difference between the intervention versus medical therapy group. And then this is just looking at a hazard ratio of subgroups, of subgroup analysis, which really wasn't very helpful either. And then the limitations here, the mean stenosis was 67%. So maybe we're not getting the people which would truly benefit. They probably already were sent to it. So 20% of enrolled patients had over 80% stenosis. Fibromuscular dysplasia were excluded and the pre-screening and deferred. Therefore, a lot of the patients were already shunted off to be treated if the physician really thought they needed it. So there's just a little bit of bias. Now, this was revisited, and basically, stenting did favor those with the highest category of stenosis. Again, this is the toppling here. So the highest category of stenosis, probably stenting did favor it. So saying like, if you have more severe stenosis, perhaps you would benefit from it. And then we also, what I didn't include in here is that those who had lower urine albumin did better post-revascularization than those with higher. And that's just what we already know. People who have chronic CKD, they're not going to benefit as much. So general treatment, we should be doing risk factor modification, blood pressure control. ACE and ARB should be the first line, and most patients will actually tolerate it. The minority will have that sustained rise greater than 30% and be intolerant of it. And that may be an indication, if you can't control their blood pressure, that they need to be stented. So a diuretic, all these patients are going to have a lot of aldo on board, right? Because they've got high renin, high aldo. So they're going to need a diuretic. You need to get them peeing off that sodium. Other hypertensives of lean and a low sodium diet. If you have a high sodium diet, you're going to be refractory to actually your RAS inhibition.
In regards to the ACE and ER, I've read on UpToDate that they have like the ones you can try it on, but is it even with bilateral renal or stenosis, you still can trial it? Do you?
Yeah.
You should try it on everyone. You're
Yeah.
open on to work.
It's still first line.
You know,
And if you do want to,
you put them on dialysis. It's okay. If you
that activity of the angiotensin too, right? because that's a lot of what's contributing to some of the long-standing damage and the fibrosis and inflammation.
And all the analysis for a little bit. Hypertension.
All right. So invasive stranodeep percutaneous cutaneous renal renal angioplasty. It's a new procedure. And then surgical revascularization. They are not without some of their own complications. I have a 15% complication rate. And then I just sort of put these quotes in here: 38 complications within 24 hours, 19 were serious. Pulmonary edema, MI, 5 renal embolizations, 4 renal artery occlusions, 4 renal artery perforations, 1 femoral artery aneurysm, and 3 clinically significant collateral embolization. So it's not like a benign procedure. So you do need to be thoughtful about it if you are going to do it. And the thing is that at this point, probably you already feel fairly confident. And I tried to be really redundant with the patients who are going to benefit from an intervention.
So it was 38 complications and 31 patients. So some of those patients had multiple complications.
I think so.
Yeah.
Yeah, I was a surgeon. I would want to do this before here.
With your what are like renal artery perf? You have to stage it after you perf.
Just dice.
And then apoembolic activity, probably largely under recognized. They do say 1.2% incidence. Higher bilateral intervention. They have some new protection devices that haven't been really studied too much. Then surgical revascularization. These are some of the indications for why you might need to do it. Similar blood pressure outcomes. The backyard cases. We already kind of talked about them a little bit, but if we go back, this is our first case. This is our guy whose still blood pressures were elevated. He had good lifestyle adjustments. And we were like, which of the following is the most appropriate management for him? And if you remember, he had like a 12 centimeter and a 10 centimeter kidney or something like that. What would you do for him?
YOLO sarc.
He'll start. Right. Add RAS inhibition and start with that. Probably not going to get much. He had a long-standing creatinine of 1.7. He had proteinuria. Creatinine was stable. You just need to stabilize him. We will never know if he's got renal artery stenosis or not.
That's not technically, but you just order as a renal doppler because I want to look at the kidneys, the kidney anyway, and then it just makes me feel better. I have a reason for that.
You can deal with
Because you can tell.
what a new. Yeah, my thing is deep eyes. I feel like it's the read isn't always as.
Oh, this all girl. It really doesn't really help to be that much.
I mean, have you like seen what you radiologists at the U are reading all these transplant kidneys? They're reading non-specific, moderate, elevated resistance. You saw it. Still at the U at all.
ER is very perplexed.
Eliminate every night.
You know, like it's fine. Some don't.
Yeah. Let's go to so remember case 2 of our guy that had a jump in his serum creatinine from 1.9 to 4 over the last year, and his blood pressure was more uncontrolled. He had new onset severe lower extremity edema. And then we saw that he had a large right kidney and a left kidney that was really small. So this is the one that we're worried about, a unilateral stenosis. And so this is the guy that got the MRA. And he had to get stented because he actually had a severe near occlusive disease.
For this, is this a real patient? This is.
He is, yeah.
So this guy creatinine 2.2 to 4 in a month. You send him to the ED, or did you do this?
I did send him to the ED, and then the workup happened at patient.
Yeah.
Yeah.
I mean, his atrophic kidney was already like 7 centimeters. Is stenting going to help? Like, it's not going to help that kidney anymore. It's already atrophied.
Well, so the atrophied one is done.
yeah.
That one's
Yeah.
that's
So he had bilateral.
so the one that was 12.5 centimeters had renal arteries.
Oh, okay.
Yeah, so the other one was totally dead. Now that doesn't mean the other one's not spitting out a ton of freedom.
So then, yeah, you would stent that, see if you can get their blood pressure controlled. If it's still crazy, then consider them in the
Right. So I can tell you what happens to him after this is that he got stented and he did well for a while. And then his blood pressure shot up. He was getting edema again. I was trying to evaluate, but I was like, well, maybe he's got an stenosis, trying to figure out what's going on. So then at that point, his renin was like 15. So then I was trying to, I was going to do renin, venous renin measurements, but I didn't know. I mean, the problem is that he had one kidney that was already, probably had a vascular event as well. It was 7.3 centimeters, but it still could be spitting out a ton of renin, right? So that one could be. And then the other one, if he had an instant occlusion or something like that, unfortunately, I think we felt like maybe, I can't remember if it just didn't feel like it was going to be safe. So I put him on, what's it called? The one that just blocks renin.
COVID and diet.
But interesting nonetheless.
Happy ending.
So at what point do you consider the nephrectomy then?
What that?
I guess at what point do you consider the nephrectomy, and the benefit to the nephrectomy is that you're thinking that
So
that kidney is the anything renin and
yes. So let's say that kidney is completely done for, but it's still spitting out a ton of renin and you can't control blood pressure. That's when you do.
and then how would you know? Is that with renal vein sampling that you would know that it's still spitting out?
Was that failing aliskiren?
So it's aliskiren's not the first line. That's not really well studied in this scenario. I put him on aliskiren because I can't remember. I actually think he had pretty high. I think I did renal vein sampling. I think he had really high renin levels bilaterally. So I don't think there was anything that we could really do about it. So I think I put him on aliskiren and it didn't really make a difference.
Wait, do you stop their other RAS blockers and you put them? Oh, I've never used that. I'm just thinking that
That was my first time using it.
Okay.
So if it's bilaterally producing a lot, you just assume that even if you took out one half of that equation, the other one would just still use it.
Unilateral liver.
But oftentimes, once people fail enough for dialysis, that problem go away.
Don't you always end up doing an MRA over a CTA? So these people are gonna come in.
Well, it depends, right? If it's kidney, yes. But if it's somebody who's got flash pulmonary edema, they've got infection. You don't get to do.
Are these people just not on Spiro because of their kidney function?
I mean, I think you can do Spiro. I mean, it can be helpful to block Aldo. It's just not the first line.
I was just thinking maybe if you're not getting anywhere with your RAS or your whatever the renin one is called.
No, I think Spiro is probably a good choice. It depends on your degree of chronic kidney disease or apnea level, and how you manage it that way.
Because they're all kind of like borderline K low.
And it's because they've got too much Aldo, right?
Yeah. So I'm thinking you can block that.
Do you spend a lot of time like about their like ASCVD risk and stuff like that? Because like a lot of these people end up dying from cardiac events. Like maybe it's outside the purview of something we should think about, but like, are you targeting an LDL of less than 70? Like, are you being that intentional about it, or put them on some sort of statin if they're not? And cardiology or whoever else should really follow that closely.
I probably ought to be more aggressive with that. I mean, I'm oftentimes just pleased that they're honest.
On some good, yeah.
And we know that in our chronic kidney disease group, like CKD, essentially 1, 2, and above should be on statins because it's such a significant risk. Yeah, but
I never pay attention about, yeah. So I'm just like, oh, they're on a statin. But I feel like some people are on like Beatty, so statins, then I should be more aggressive with like,
And there's like PCSK9 inhibitors and stuff like that. I know that could really get it down. So I feel like these people are such bad vasculopaths and then they just die.
yeah. Do you start external? I mean, the thing is that really over time, we probably all ought to be better at just being primary care docs, right? Because CKD, I mean, we see these patients as much, if not more, than the primary care docs, and we're more comfortable using medications and dosing medications for our advanced chronic kidney disease patients. And that includes our statins, making sure they're on the correct statin. There are certain ones that we probably ought to be more careful with. PSK, PSCK, PCS, with K9s. I've never prescribed it actually. That was like for my primary care or after my primary care days anyways as a resident. So I'm just familiar with how effective it is, but we probably ought to be better at it. Did you guys know that I just put together a diabetes and obesity elective for you guys? So you must or will be rotating with the endocrine room. Yeah, so it'll be some at the GA and some at the university. That's cool.
Oh, I noticed the PCP asked if I could order a GLP because I asked them to order it.
And so
They were like,
we just need to know how to up titrate and how to down titrate insulin that are on insulin.
Oh, yeah. Were they
But not saying sense. So I know we're getting off this topic, but for obesity, we know obesity worsens our risk of chronic kidney disease. And that's another way we can get around getting somebody on a GLP-1 agonist if you've got them totally maxed out on everything else and they don't have diabetes. You're like, oh, they're obese. I'll put them on this. And we know that while we don't have all of the data, we've got the surrogate data saying that it does reduce albuminuria in our patients. And it sort of knows if it's like weight loss, but they also think there is some anti-fibrotic and anti-inflammatory components of it. So
it sucks at the VA, not the VA, at Timber Health. Unless you have diabetes, they will like a BMI of 75. They'll still be like no, which is insane.
it is a deep covers all of these.
But then if you have a BMI of 75, will they cover bariatric surgery?
Yeah, which is crazy.
what? But this is still cited to bariatric surgery in terms of outcomes from
Quotations will want surgery.
yeah, you'll cover this surgery. You'll say they might your way down, not qualify for
Diabetes, like a BMI.
Make you do like sugarology. Beat plus weird.
stand and take. Y'all just be like,
It's actually see no eat ice cream, but that's primary for my. It's not.
Nice to like sleep. Give it. Can and see those dude likes the stuff.
It's not specific doses now, right? It's like what you'd get in trouble. Because in each year, just like okay, you ask many weeks and do.
I just feel like it's got a bad release. I already April's mask. That's the answer.
Okay, so
also remediate that